anterior to this one is the optic chiasm, and this is the mammillary body. This area is the hypothalamus.
So thank you, Kaushik, once again. I think you have addressed all the questions very well, and I guess the residents have picked everything up. So with this, we come to the end of the radiology part from radiation oncologist point of view. So of CNS of brain. So we would like to go to the next talk, and over to Devanjan once again.
Yes, we had a really interesting question and answer session. Thank you, Kaushik sir and Anupam sir, for your lucid discussion. The day before, Professor Dr. Shalin Kumar had walked us through the conventional planning of brain tumors per se. Today, I would like to welcome none other than Dr. Kanu Charan Patro to start with his session on conformal planning in gliomas and pituitary adenoma. Sir is the head of the Department of Radiation Oncology at Mahatma Gandhi Cancer Hospital and Research Institute at Visakhapatnam. Sir, please go ahead with your talk. Kanu sir, are you there?
Hello.
Yes, sir, you are audible.
Yeah. Can you give me 2 minutes more? Just I'm downloading.
Sure, sir. Sure, sir.
Just give me 2 minutes. Hello.
Okay, sir.
No.
Okay, sir.
Hello.
Yes, sir.
Hello. Hello.
Yes, sir. You are audible.
Audible, but you people have not allowed me to share the screen. So that's why please allow me in the just sharing the screen.
Sure, sir. Anupam, sir.
I'm doing it.
Okay.
Yeah, it's done.
Done, huh? Okay, okay. Okay.
Sir, can you please share your screen?
Yeah. Now it is okay.
Yes, sir. It is visible and you are audible as well.
Okay. So I am sorry for the technical glitch. I am extremely sorry. So today I am going to tell about the GCP parameters in glioma and pituitary. GCP is not nothing. It is GTV, CTV, and PTV. Okay. So today first I will complete the target delineation in glioma. After that, pituitary tumors I will tell you. So today in the two topics, I am going to share you mostly low-grade glioma and high-grade glioma. If you see the WHO 4th edition 2016, there are lots of glioma classifications are there. But in 5th edition, it is so easy. Adult diffuse type like glioma and glioblastoma, IDH wild type. So they made it very simple. So to target delineation of glioma, we have three things are the three guidelines: NRG, brain tumor specialist consensus guideline for GBM, and ISTRO-ECROP guideline for target delineation of glioblastoma, and glioma consensus recommendation from MR-Linac International Consortium Research Group evaluation. And I can see this, tell you some patterns of glioblastoma multiforme from limited margin and concurrent temozolomide. So if you see the target delineation in glioma, there are high-grade glioma and low-grade glioma. Usually low-grade glioma, we should take the T2 player abnormality and give 1 to 1.5 centimeter margin as a CTB. But in WHO grade 4 glioma, there are two guidelines existing, is actually URTC and RTOG guideline, and this is the grossly CTV is 2 to 3 or 2 to 1.5 to 2 to 0.5 centimeter, and PTV is accordingly your institutional practice. Let's go in the detail. So some facts before going to the low-grade glioma and high-grade glioma target delineation. We should understand the radiology first. Diffuse astrocytoma, also referred to low-grade infiltrative astrocytomas, is known as a WHO grade 2 tumors. Commonly, astrocytomas are confined to white matter. However, oligodendroglioma is frequently cortical-based tumor. Although contrast has been enhancement seen associated with high-grade gangliosity, but contrast enhancement may be seen in up to 20% of low-grade gliomas. So if you see, this is an oligodendroglioma where you can see the calcifications and mostly cortical-based tumors. This is the cortical-based tumors. You can see the calcifications. And low-grade glioma in CT images, you see hypodense lesion. And you can see T2 CT hypodense lesions. In T1 lesion, it is mostly hypointense. You can see this is a hypointense lesion in T1. In T1 contrast, usually they does not enhance. However, it looks T1 as well. T1 contrast looks almost same. So nothing, don't worry if it looks the same thing, that is a low-grade glioma, but it has a different abnormality. So if you go to the T2, you can see that tumor, it looks hyper intense in T2, and this is mostly your tumor. But if you T2 flare, and you can see here, this is the T2 flare abnormality. So if there is a T2 and if you see, this is the T2 previous picture, this is a T2 and this is a T2 flare. If you see the intensity of the two lesions, it looks different. If they looks different, definitely most of the cases it is a IDH mutated gliomas. If it is not, it looks equal, then it is a IDH wild type. Let's see, this is called T2 flare mismatch sign. You can see radiogenomics T2 flare mismatch sign, where you can see the T2 and T2 flare mismatch. Actually, the tumor should look like same, but it is here, it is a mismatch. So it is mostly IDH mutant tumors. In low-grade gliomas, if you see, there will be no diffusion restriction because it is low grade, and there will be no diffusion no diffusion restriction. In DWI, in ADC map also corresponding is a ADC is nothing, it is a T2 DWI. So here there is no restriction, so looks normal. In if this is a susceptibility weighted image, in which you will see the bleeds and calcifications. If you see the bleeds in this tumor or calcifications, you will have to go for the SWI. So this is the susceptibility weighted image. In perfusion scan also, you will not find anything, there is a hyperperfused area, because T2 gliomas are low grade gliomas. If it is a high grade glioma, you will corresponding this area, you will get the hyperperfused area. So imagine if you see the same thing extrapolate in the high grade gliomas, this is a tumor in T1. T1 contrast is a highly enhancing lesion here, as you comparing to the contrary to the low grade gliomas, where it is an equal same hypointense lesion, but in high grade gliomas always it is an enhancing. And T2 flare abnormality, you will get good edemas. And if you see the perfusion scans, you will get hyperperfused in the corresponding area. So sometimes PET also people are finding in the like PSMA PET and fluoromethyl PET, but these are mostly useful for in the irradiation settings. So no definite role of PET imaging. It is suggested that PET imaging, methionine PET, F80 PET useful in the context of re-irradiation because of extensive post-therapeutic imaging changes may be more accurately by PET. So if you are going for the re-irradiation, you go by the PET scan. Otherwise, no need. You have to see the choline shear creatinine ratio also. If it is a choline creatinine ratio is more, it is giving towards, indicating towards the high grade glioma. And if you see, this is the low grade gliomas, choline creatinine ratio usually 1.5 to 2. In high grade gliomas, usually more than 2. You can see the choline creatinine ratio in the low grade gliomas and high grade gliomas. So, Paul's about the contouring. Contouring should be performed on contrast enhanced post MRI rigid after fusion with CT. Typically, low grade gliomas do not enhance. So, tumor should be contoured with flare and T2 sequences. Don't ignore the T1 also, T1 contrast also. Some 20% cases they enhance. And same thing in pre-op imaging should be referred to ensure the rationale in the target delineation. So, before going to the target delineation, go through the operative notes. You should see the solid part, cystic part, necrosis, and whether it is taken totally or residual. Prerequisites before going to contouring, as per the pre-op scan, preoperative findings, perioperative findings, histopathology report, ISC markers and molecular study, as well as the planning MRI. So in pre-op scan, what we have to see, you will see the T1, go through the T1 contrast, T2 flare, diffusion, ADC perfusion, and MRS. Pre-op scan, it will guide to you which is solid part, what is cystic part, what is T2 hyperintensity area, what is a diffusion restriction area, what is hyperperfused area, where MRS is more raised. Pathological finding also very important, whether what is the size, where is the micros, you can see the hypercellularity, whether it is there, nuclear atypia is there or not, microvascular proliferation is there or not, or necrosis is there or not. So these things you have to find out properly. So before planning, you have to ask for a planning scan of a MRI. So usually in the hospitals, those who don't have a MRI, you have to import from the DICOM CD, or those having MRI, we have to go through the 1 mm slice, no gap, no tilt, neutral neck, 5:1 matrix, full FOB, vertex to C5 level, you have to contour, because whole brain and everything doses if you want to see, you have to go to till C5. CT-MR should be done with minimal time gap. Both CT-MR needs contrast scan. PET imaging is needs for the irradiation, and FS-PGR sequence, empirical sequence is needed to proper anatomical delineation of the optic apparatus. And you need a DICOM CD to import the images to your MRI planning system. Let's see one thing, one case study I will show you. T2 flare pre-op. You can see here T2 flare pre-op, and this is the T1 contrast pre-op, and this is the T2 flare post-op, and a T1 contrast post-op. So this is the you can see here again, I'm showing here, this is the T2 flare pre-op, T1 contrast pre-op, this is a T2 flare post-op, and this is the T1 contrast post-op. So you have to, this is a collection outside the skull, this is the scalp collection in the subdural, skin area. So you have to go for the total post-op scan. So you should not rely on the post-op scan, you have to go for the pre-op scan also. So this is a sequence called FS-PGR sequence and GE, or empirical sequence in Siemens. So why it is important, you will see this sequence in the optic apparatus so nicely. You can see here optic chiasm is so nicely. So always asking for the FS-PGR sequence, it will delineate your optic apparatus properly. So then that case again I'm continuing CT post-op and extrapolation of GTV from the pre-op MRI. So you fuse the post-op scan with pre-op T2 and T1. This is the extrapolation of the MRI. And usually 1 centimeter for the T2 and usually 1.5 to 2 centimeter for the grade 3 and grade 4 griomas. So after giving the 1 centimeter or 1.5 centimeter margin to your surgical cavity or pre-op area is important, and then you give your PTV. So, but this is not the sufficient. It is a very crude method of doing your GTV, PTV, and CTV. But how to address the all situations, you have to understand the trimming yourself, but how? So where is trimming is required? Inner table of skull, thorax, corpus callosum, ventricle, optic apparatus, brainstem, and tentorium. So these are the recommendations from the MR-Lina Consortium recommendations. I will go one by one. So suppose you are the green is your CTV. Never trim your CTV in soft tissue window or brain window. Always you trim your CTV from the bone window. So in bone window, if you see this is the soft tissue window, this is a bone window, you can see the remaining part of the brain you are leaving beyond your CTV. So it is very important when you are trimming your CTV from bone, always do in the bone window. Trimming along the thorax. People think that if tumor is confined to the one side of the tumor, one side of the cerebrum, say they don't they just trim along the falx. Never do that. If your tumor is along the falx, at least go 0.5 mm towards the opposite side. It is recommended. Trimming above the falx example I am here showing. Never trim the along, even in post-op also, and you never trim along the falx. You should go 0.5 centimeter opposite to the falx for the trimming. Again, it is a trimming along the corpus callosum. Corpus callosum, anteriorly it is called genu, middle is part body, and posterior part is called splenium. So you can see genu, body, splenium, and splenium. If you see the cross-sectional images, these fibers are communicating with each other along the midline. You can see here, these are the corpus callosum here, this is the corpus callosum here, this is the corpus callosum. So if your tumor is in the corpus callosum, you have to go to the opposite side, never trim in the midline. So I'm showing one tumor, though it looks like here, you can see that it goes through the anterior part, genu, it goes opposite side. You can see if this is goes to in splenium part, it goes to opposite side. So never underestimate your tumor. We have to follow properly to bring your CTP to the opposite side. Trimming according to the corpus callosum, you should do the you go through the coronal section, sagittal section, axial section, and go to the your CTP. Your CTP should go to the opposite side if it is crossing in the anterior commissure, posterior commissure. All parts you have to see and go through the tract. Trimming of the optic apparatus. If your tumor is inside involving your optic chiasm, optic nerves, you should no need to trim. What your CTP is approaching on the optic chiasm and optic nerve, you should trim. Second point, optic tract. After optic chiasm, optic tract starts. If optic tract is the your CTP is overlapping, never do that. Don't trim your CTP from the optic tract. You should trim your CTP in the optic chiasm and optic nerve. Remember, if your GTV is on the optic chiasm and optic nerve, don't try to trim it. Trimming along the ventricle. When we have a blind belief that the tumor, if it is not going to the ventricle, usually gliomas. But remember, if your glioma is touching the ventricular wall, you should go inside the 0.5 centimeter inside the ventricle. So this is the recommendation. You should not you drag your CTP inside the ventricle 0.5 centimeter. So don't trim along the wall. You should go into the 0.5 centimeter. And another trimming on the brainstem. Suppose your tumor is in the basal ganglia. Your tumor is in the basal ganglia or tumor in the thalamus. When you give margin, your margin goes to the automatically to the brainstem. So there are white fibers connecting to this brainstem and optic chiasm, brainstem and thalamus, and brainstem and the basal ganglia. So if your CTV going to the brainstem, don't trim it. Trimming about the brainstem, as I told, you should not trim directly from the CTV. A brainstem, you should go for the trim into the no need to trim the from the brainstem if it is your CTV is going to the brainstem. If your tumor is located in the thalamus or basal ganglia. Trimming along the thalamic area. If you want one of the tumor is situated in the thalamus, there is a called interthalamic adhesions. In interthalamic adhesions, that tract fibers carries the tumor. So if your tumor is confined to the one thalamus, never trim your from the midline. Your CTV should cover the other thalamus. So this is the thing you can see here, interthalamic adhesions. So this is the tumor where you able to you are very close to miss. So never if your lesion in the thalamus, your CTV should include opposite thalamus. So this is all about the low-grade glioma, and I will tell about the high-grade glioma. High-grade glioma is the playing with the triple concept, is the excisional cavity, enhancing component, and edema, triple E. So there are two protocols, single phase 60, two-phase treatment is the RTOG, which gives 46 gray phase 1 and 14 gray phase 2. So if you there is no head-to-head comparisons because Europe never compare with America, America never compare with Europe. So we have to, the only retrospective studies are there whether URT is better or RTOG better. But all retrospective studies shows that URTC is better because RTOG gives high margins. It gives 2 centimeter margin beyond edema. Sometimes it looks whole brain. So two-phase treatment, more tedious, more margin. So mostly people follow the EORTC, where EORTC covers surgical cavity, enhancing mass, surgical excisional cavity, and edema. And you give 2 centimeters margin, and that 2 centimeter margin should cover edema or T2 abnormality. PTV, whatever you follow, either 3 mm, 5 mm, according to your institution, you follow. So there is a called MD Anderson study here. I've said there are 48 primary GBMs. So they are all retrospective studies. These are the this is the RTOG. They compared with RTOG, and this is the down is the RTOG and upper is the URTC. So they have given 2 centimeter from the GTV to CTV, but here they given 2 centimeter to the edema. So near down is the RTOG and upper is the URTC. So they found that almost similar recurrence, either central recurrence, infield recurrence, marginal recurrence, distant recurrence, all recurrences are in RTOG or URTC almost similar in the retrospective study. Another study from the patterns of failure comparison between the target volume delineations with the glioblastoma with radiotherapy and temozolomide. So they defined central recurrence, infield recurrence, marginal recurrence, and distant recurrence. Central within 90% of isodose. Infield recurrence is the 50 gray volume or 46 gray volume in RTOG. Marginal volume when 95 when the less than of 95% recurrence was outside the high dose volume. Distant when recurrence was outside the RT field, like the less than isodose per 20% isodose volume. If you see again the RTOG plans and Anderson plans, this plan, there is just recurrences almost the same with RTOG and URTC. So in conclusion, the use of target delineation using postoperative residual and activity plus 2 centimeter margin is appropriate for patients with GBM with standard RT and concomitant adjuvant temozolomide in the like URTC settings. So what should be our the GTV? Surgical resection cavity plus residual enhancing tumor post contrast T1 weighted MRI scans, which should be taken. So in low grade glioma, you should take the one contrast abnormality, but you should careful secondary gliomastomas that non-enhancing area may be component of the tumors. So always remember T2 abnormality is the key factor. Or T2 flare abnormality. If your 2 centimeter is not sufficient to cover the T2 or flare abnormality, enlarge your CTV to cover the T2 abnormality. Again, same trimming. Again, I told as a bone window, you have to take for a trimming of the bone window. Flax area, you should go to 0.5 centimeter along the flax. Ventricular area, you should go to the 0.5 centimeter inside the ventricle. Trimming in the upper aorta, if suppose some and how should I go inside the treating the optic chiasma till 60 gray or brainstem is till 60 gray. So if you see the toxicity, before toxicity comes, patient dies. So don't worry. Usually I go till 60 gray with clearly in GBM patients or IDH wild type patients. You don't, so if when your toxicity comes, that time patient will not be there. So don't worry for the optic apparatus or brainstem. If you are touching the 60 gray, try to save. If you are not able to save, at least your GTV covers well. Thalamic area, as I told before, there is because of interthalamic adhesions, you have to go inside. Trimming along the brainstem. So if your lesion is the temporal lobe, your lesion is the basal ganglia, your lesion in the thalamus, your CTV can include some part of those brainstem. Don't try to trim it. So there is another study. There is a study called Adult Brain Tumor Consortium Guidelines. So they, what is the Adult Brain Tumor Consortium Guideline? They started with this is the website of Adult Brain Tumor Consortium. They given different guideline, GTV1, GTV1, T1 enhancing, non-enhancing tumor volume, GTV2, T1 enhancing tumor volume, and this is the CTV1-2 is the only 0.5 margin, where URTC, RTOG, we are going for 2 to 0.53 centimeter. This Adult Brain Tumor Consortium guideline, they told you can take with the 5 mm. Even there is a mostly infield recurrences are more, distant and marginal recurrences are less. And in this study, this study, Birmingham study, they found that though more than 80% of the recurrences in the infield recurrences, even taking the 5 mm margin, but at this juncture, we should not follow Adult Brain Tumor Consortium guidelines. Let's wait for some more studies. We can see there are this is the study. I no need to go into deeper inside how the tumor proliferates. Is the tumor there are 3 types of tumors. One is the type 1, type 2, type 3. Type 1 is the tumor containing subventricular zone, tumor involving the cortex, and type neither containing the subventricular zone or infiltrating the cortex. There are 3 types of the tumors. So though if you see the perineural spread, and the yellow is the perineural spread, and red these things are not seen in the type 3 tumors. So if you see all these things are, if you take in the account, direct invasion is the red color, perineural spread is the yellow color, subpial growth is the brown color. This brown color, you can see the subpial growth. Perivascular spread is the blue. Black line, tumor containing area. This is the black line, that is your tumor containing area. This is black line. So this, if you find out these things, so grade 3, grade 4 tumor, and you see the infiltration property. If you see the infiltration property, grade 4 tumor have a more infiltration, around 2.5 centimeter to 3 centimeter. Grade 3 has a less infiltration. Type 1, type 2, type 3. Type 1 tumors having more infiltration comparing to the type 2 and type 3, just as I told, type 1, type 2, type 3. Type 1 has a more infiltration. Methylated tumors have a more infiltration. Mutated, IDH mutated, wild type has more infiltration, and non-codelated tumors are more infiltration. So these, type 1, type 2, type 3 is non-significant. So you can see those are high grade, those are non-mutated, those are non-codelated, they are gives more infiltration. But methylated has a more infiltration comparing to unmethylated. It's very important to remember. So whether IDH patterns of failure in IDH mutated low-grade gliomas after radiotherapy, is there a implication of margin reduction? So again, in this study, they found patterns of failure in IDH mutated and low-grade glioma in radiotherapy. So recurrence was classified as a central, inside, edge, and outside. As said before, 95% of more recurrence in the central, 80 to 95 inside, edge 20 to 80%, outside more than 20%, outside is the 20%, outside of the 20% isodose. So they found, they again RTOG, URTC guidelines, they studied, they found that most of the central recurrences, so this is again a retrospective study. They taken GTV, hypothetical 5 mm volume, and original CTP. So in the hypothetical 5 mm volume, that is hypothetical 5 mm CTP, 67% are central recurrences. But though even IDH mutated 67% are central recurrences comparing to the 82% of original CTP, still at this juncture, we should not trim our margin in a IDH mutant gliomas. We have to wait for the more studies. So in summary of low-grade glioma, GTB is the cavity is equal to the cavity. CTB 1 centimeter from T2 or flare in hyperintense area of T2. CTB expansion is limited in the absence of contiguous white matter tracts. Trim the CTB from skull in bone window. 5 mm along the ventricle and flux is applicable. Interthalamic extension of CTB if needed. CTB should be limited without additional margin to the optic nerves and chiasma, but optic nerves should not be excluded from the CTB. Brainstem is the anatomical barrier, but if there is a thalamus or international capsule is involved, you should include, your CTB should include commissural tracts connecting opposing cerebral hemispheres. CTB should cross the contralateral hemisphere if the enhancing or T2 flare abnormality like in corpus callosum, anterior commissure and posterior commissure. In summary of high-grade glioma, GTB, your GCP parameters should include EEE. GTB should is equal to cavity plus enhancing area. CTB 2 centimeter include the flare abnormality and contrast area. Trimming of the skull in bone window 5 mm from the ventricle and flux is applicable. Intrathalamic extension of CTB if needed. So this is all the all about the low-grade glioma and high-grade glioma target delineation. Yeah. In next 10 to 15 slides are for the pituitary. Any doubt now you can ask me about the glioma contouring. Dr. Anupam?
Yeah, sir, there is a question from one Dr. Abhay. He's asked, like you have already addressed this, like for contouring of brain tumor, which guidelines should we follow? URTC or RTOG for a daily basis?
See, there is no comparison, as I told, no comparison between Europe and America. So if you see the all retrospective studies, they showed that same type of recurrence, either you follow RTOG or we follow URTC. So I follow usually URTC, which is a single phase treatment and which is also smaller margin. So I follow URTC. Choose yourself according to your convenience.
Okay, sir. He again asks that if the tumor is abetting the brainstem, wouldn't inclusion of the brainstem in CTV result in a brainstem injury and possibly death, as we are overshooting the brainstem tolerance dose of 54 gray, while the tumor dose is 60 gray?
So two things I will tell. When it is a low grade glioma, you are going for 54 gray. Don't worry. You include the CTV in the brainstem. If you are going for a high grade glioma, patient is when your toxicity comes, patient dies. So nothing to worry. And some studies shows that the brainstem also 0.30, 0.3 cc or even more. We are underestimating the brainstem prevalence. So in a low grade glioma, you are going for 54 gray. In high grade glioma, you are going 60 gray. So in low grade glioma, 54 gray, where don't accept the hotspot inside. Keep it 54 gram Dmax. And in low high grade glioma, I usually include, because if it is a high DH wild type or high grade glioma, why should I worry when patient is not going to survive more than 2-3 years?
Yeah, sir, I think you're right. But even also, I think what sometimes we do is we look into the dose 0.1 cc dose of
that's why I told.
Yes.
That's I told. Don't accept the Dmax beyond 60.
Exactly, sir. So we have another.
Dr. Anupama and Dr. Kanu, this is Dr. Abhishek. So can I just make a quick comment here? So I completely agree that in high-grade gliomas, it is important for tumor control and brainstem doses. You should not be, they should not be sacrosanct. I just wanted to comment that many centers also have another practice. They do something called a brainstem surface and a brainstem core. So essentially, they contour 3 millimeter within the brainstem as well as the surface, and they have different prescriptions. So 59 or 60 gray for the surface and 54 gray for the core. So this is essentially because it has been found that the core tolerance is slightly lower than the surface tolerance. So looking at 0.03 cc doses, which is the Dmax dose for the surface and also for the core. And to keep the core doses to 54 gray, if it is possible, yes, for the brainstem, exactly.
There is a contouring guideline for the brainstem. Brainstem, what you contouring is not exactly brainstem contouring. So actually 3 mm is the surface and 3 mm, beyond 3 mm is the deep area.
Exactly, and they have different constraints. I mean, we can try to give different constraints. Exactly. Thank you.
Exactly. Shows it is your a person's choice, because if you underdose in the high grade glioma in that area, you will have a recurrence. But I don't. I try to accept 60 gray even in a high grade gliomas. Low grade gliomas, I keep Dmax 54 in the brainstem.
Yes, sir. Sir, there is one more question is asked to summarize the low grade glioma contour once more. Your summary slide for low grade glioma, please.
Okay, you want more this one?
Yes, sir. Yes, sir. This one, yes.
So the underline is always take the low grade gliomas when you are contouring. Take the T2 player abnormality pre-op. This is the dictum, but don't underestimate the contrast image also. So GTV is your post-op cavity. CTV 1 centimeter from the T2 or flare hyperintense disease. CTV expansion is limited in absence of contiguous white matter tract. So we are not DTI images are we are not doing, and everywhere is not available. So you have to be very cautious when your CTV is trimming. So trim is the cream. So you always understand the trimming is the very important. Trim the CTV from the skull in bone window, not in the brain window.
Hello.
Audible?
Yes, sir, you are audible. Please continue.
5 mm along ventricle and flax is applicable. Intrathalamic extension is needed if CTV is going to the opposite side. CTV should be limited by without additional margin to the optic nerves, optic chiasma, and optic tract. Remember, this is very important. If your GTV is encroaching the optic nerve, optic chiasma, don't edit it. But if your CTV is encroaching it, you should edit. This is the line. And optic tract is not the we have not worrying for the 54 gray or 60 gray. You should not, your CTV is going to the optic tract, you should should not edit from the optic tract. Again, as I'm giving an importance, if your lesion is in thalamus, internal capsule, temporal lobe, if it is going, your CTV is going to the brainstem, don't try to cover in the brain part of the brainstem. And there is a commissural tracts going from the anterior commissure, posterior commissure, corpus callosum, splenium, all are going to the opposite lobe. So this we have to go through the sagittal section, go to the coronal section, go to the axial section, and contour it. Hope I have cleared your doubts.
Yes, sir. Yes, sir. Thank you so much, sir. So we don't have any further questions. So you can go ahead with the pituitary adenoma part, sir.
Okay. Thank you very much. So see, if you go to the imaging, this is the sella or hypophysis fossa. This is the optic chiasm. This is the this is the posterior pituitary. This is the anterior pituitary. This is the pars intermedia. So if you see, this is the optic chiasm. This is the pituitary stalk. So this is the called acute angle. You can see this acute angle, optic chiasm and pituitary stalk. So this is the anterior pituitary and this is the posterior pituitary, and both are going to the thalamus, hypothalamus. There are two structures are very important. One is the cavernous sinus, and this is the optic chiasm, and this is the infundibulum hypophysis tax. So, and this is the sphenoid sinus. So you can see this is the pituitary, this is the infundibular stalk, this is the optic chiasm here. This green dotted line is the optic chiasm, and this is called supraoptic recess. So this is the infundibular recess. So this is again, this is the pituitary gland. There are two internal carotids, bilateral, 3 dots, and all cranial nerves like 3, 4, 5, 6, 1, 2, except the 3, all are in the cavernous sinus. Mostly the tumors are the inside the tumor. They usually try to invade the laterally to the cavernous sinuses. So these are the bed sign. You can see the bed here, the cavernous sinus, cavernous blood vessels and nerves. And this is the based on the schematic presentation in the skull. So this is the cavernous sinus. So it is usually enhances. So your pituitary tumor is enhancing, your cavernous sinus is enhancing. So it is a very tough to see in the CT scan how to differentiate the cavernous sinus involvement. So if you take the normal pituitary in MRI pictures, this is the anterior, this is the MRI, this is the plain MRI, T1, this is the contrast. Usually if you take this, the posterior pituitary is like a straight line, it is usually hyperintense. If you give the contrast, that is also slightly hyperintense. The posterior pituitary is more hyperintense than the anterior pituitary. So you remember in that. Another thing, this is the part of the pituitary. If it is microadenoma or less than 1 centimeter, my microadenoma more than 1 centimeter, and this is very important. You have to see how the pituitary tumor looks and how it enhances. I will come for imaging more than 30 minutes after intravenous contrast also help detect microadenomas which then appear as a focal hyperintense lesion related to the surrounding gland. So delayed image also important like meningioma in the pituitary gland. Encasement of cavernous sinus is attributed by adenoma or greater than equal to 60% to be a specific sign for the cavernous sinus invasion one study. Head-packed surgical. So after the transnasal surgery or transpinodal surgery, they put the fat-packed material in the to prevent the CSF leak and packing. So how to differentiate that packing material? We have to take the fat set sequence. So this is the pituitary macroadenoma. You can see here. There are two gradings because of the time constraint. I'm not going to the pituitary details. Again, I will take it will take me to 1 hour to understand the pituitary details. And Dr. Anupam told me, sir, you have to finish within 1 hour. So, so planning MRI for pituitary adenoma. So as I told in the glioma, pituitary adenoma has a specific planning MRI. Planning MRI is MRI brain, T1, T2, flare, 3D FSPGR sequence for the optic chiasm and optic nerve, optic tract delineation, no gap, no tilt, neutral neck, 1 mm slice, 512, 512 matrix. Specific sequences are required if you want to do the contouring, FEDSAT sequence or star sequence to differentiate between the packing material and pituitary tumor. You can do extra Fiesta sequence. It takes another 10 minutes to take a Fiesta sequence or CIS sequence. You can delineate properly about the cranial nerve and brainstem. So this is the we send a patient for the pituitary. We need contrast 3 mm or less for the generally packing material FEDSAT sequence, optic chiasma, CIS or FSPGR sequence. Cavernous sinus involvement you can see in the T2 and T2 flare. So you can see here in all blood vessels in T2 looks darker. You can see here. So if you see in the T1, you cannot able to differentiate whether it is involved with the cavernous sinus or not. But you can see in the flare, you can see that it is not clearly involved. It is pushed. So another sequence is called FEDSAT sequence, head saturated sequence or star sequence, because after the surgery, they put abdominal fat, gel foam, muscle, fossa. So if you take the fat suppressing images, you can able to differentiate the packing materials and the pituitary. You can differentiate easily. You no need to give extra, include the fatty material and hyperintense area in your GTV parameter. there are various guidelines. London Cancer Guideline you can find easily on the net, and there are usually 45 gray. GTV should be MRI CT fusion, and include the cavernous sense bilaterally in a CTV, include CTV by 5 in the direction of to ensure adequate coverage of sphenoid where the transspinal approach has been employed. PTV is equal to 0.3 to 0.5. So what I do, the tumor bed is defined in the enhancing mass in the post-contrast T1 MRI. CTV is equal to GTV, but in as our practice in Tata Memorial Hospital, we give 0.5 centimeter whatever the GTV. And if you see in the London Cancer Guideline, include the cavernous sinus bilaterally is a compulsory. Extend the CTV in the directions to spinal sinus where they did the surgery. So whenever there is a doubt, don't trim your CTV. Give the CTV to include, if you are not able to have a star scan, you have not have a saturated scan, we don't have any T2 MRI, please cover it, because we are going for 45 gray or 50.4 gray in pituitary adenomas. Even if you give 50.4 gray, your optic nerve doses and optic chiasma doses usually 50 gray, 50.4 gray. But if you miss something, re-irradiation is a very difficult. Your resurgery is very difficult, and patient has to suffer a lot moving from the hospital to hospital. So don't worry for the optic chiasm, don't worry for the optic nerves, because you are going for the 50.5 gray and your tolerances for the optic nerve and optic chiasm is 54 gray. So why should we worry? If you have no proper CTV, MRI, no proper saturation guideline, saturated images, please cover adequately cavernous sinuses and all abnormalities. So some people think that 50 gray or 45 gray, there are various studies which shows that there is no efficacy differences between the 45 gray or 54 gray. So usually either you are 45 gray, you are correct, 50 gray is also correct. So planning generally.
Sir, we would like to close in 3 minutes.
No problem. So generally with 3D-CRT plan, this is the classical 2D plan. This is the IMRT plan where you should avoid the anterior beams. Arc plan, you can see this arc plan, but it is not a good plan. So there are various plans we have trying to publish in our study. This is called butterfly arc, where you will get elliptical doses and you will get more temporal lobe doses. This is the full arc, where your anterior chamber doses will be more if you go for the full arc. If you go for helmet arc, where anteriorly is the deficient on the posterior and bilateral 3 single arc, there will be more confinement and the anterior doses will be less. Then Alexander arc, where in Alexander arc, where the vertex arc, otherwise known as a vertex arc. So you can see more confinement, and if you see, this is the comparison between the various arcs. This is the butterfly arc, full arc, helmet arc, and Alexander arc. And this, if you see in full arc, the anterior chamber dose is very high, and even though PTV coverage is better with the anterior chamber cover with full arc, but the anterior chamber dose will be high with full arc. And so this is all about my pituitary presentations. Hope I have confined to your time, and if any doubts, you can have a questions. I love to take the questions.
Thank you, sir, for such an engaging talk. Residents or anyone in the audience, if there are any questions, please feel free to type in the question and answer box.
I guess we still have 1 more minute before for our next talk. I mean, so I think sir has done brilliantly for the time he has been given, and because he has been asking me, he will need an hour to talk on these two, and I believe sir has removed many of our doubts. So I don't see any further questions, and I think Devanjan, we are good to go for the next talk. Thank you so much, so very much, sir.
Okay, thank you for inviting. I hope I have cleared your all doubts. And my presentations are available in slides, sir, or any people interested, email me directly. I will send the presentation.
Thank you so much, sir. Thank you so much, sir. Yeah.
Sure, sir. Thank you so much, Kanu, sir. We would go forward in our class. The last session of the day is on conventional and conformal aspects of craniospinal irradiation and hippocampal pairing radiotherapy. And I would like to welcome Professor Dr. Devnarayan Datta to commence this session. Sir is the head of the Radiation Oncology Department in Amrita Institute of Medical Science, Kochi. Sir, please commence. Sir, you are not audible.
Now I'm audible?
Yes, you are audible now, sir.
Thank you for the invite, and it is my pleasure to be here. Now, one thing, I'm not able to.
Sir, are you not able to share the screen?
I'm not able to share the screen.
I don't know what's wrong happening. So I'll just try and do one more thing to you. I have already made you.
I'm not able to share.
Can you just try it once more, sir?
Yeah. But here, see the basic. So someone can help me, someone, because so now.
Can you see if you are able to share the screen?
Share the screen. Yeah. Now I'll be able to. This is something which I.
Just see at the bottom there is a share screen icon.
Yeah, but they're not allowing to share. Why?
Should not be like this. I'll just check once more. Because I have already made you the host and you're the co-host as well.
See, I don't know what's happening with my computer. This Apple is not sometimes.
Okay, I think you are using a Mac, right, sir?
Yeah. So can I do one small thing? I'll just give me 1 sec. I'll forward you the presentation. Is it okay?
Yeah, you forward me the presentation, then I'll share the screen for my end, sir.
Hello, Dr. Devnarayan.
Yeah. Hello. Tell me.
Okay. We are waiting for your to listen from you.
This is Kanu, sir.
Yeah.
I'm sorry.
No problem, sir. You just mail me your PowerPoint and I'll try and share it from my end.
Yes. It's not coming. Send me that towards me. See, we can. I'll just share the presentation, and we can have a talk also between whatever the queries are there. We can actually have some doubts are there, and anyone have any questions before still it gets started. We can actually work on that. Now, when we are talking about craniospinal radiation, it is one of the most complex and the fascinating aspect of radiation therapy. Now, in last 30-40 years, actually, I took slides from my old presentations, which I did in TMH a few years back. So the same thing we actually can do, because not much has changed in conventional radiation, which most of you, I think, practice. Now,
sir, if you want, I can share the slides from my end.
I'll just sharing the presentation, and you can. Yeah, I have sent it. Can you send the first presentation? That will be good. One written. Now, before during that time, he set up the system. If anyone have any queries, we can talk now about the craniospinal radiation, which is one of the most fascinating form of radiation therapy, where we are treating a large volume area with a dose which is many times is higher when you're considering a big volume of disease we are treating. And there are multiple beams, and there is a junctions, and we have to take care of the junctions. So, and we can't afford to have a high dose region inside, and we cannot afford to miss it also. So this is a classic example where we cannot miss any area which is the target. We cannot give high dose to any area, and there are multiple junctions, and we have to ensure the junctions are proper. So the contouring, the planning, and the execution, all the three has to be appropriate to deliver a proper craniospinal radiation. And you know, there are two studies which actually has audit. It has been done. Anupam, have you got that presentation? Anupam?
Not yet, sir. You have, I think you have mailed in the academics this thing. Can you mail it to me, to my personal ID? Dr. Anupam Datta, ANUPAMDATTA@gmail.com.
Sir, in the meantime, I think Dr. Arnav Ghosh has raised a hand. Dr. Arnav, do you have any question?
Yeah, Anupam Datta at
DRANUPAMDATTA@gmail.com.
Yes, now. Yes. Yeah. Now tell me.
Dr. Piyusha, do you have any question?
Actually, we can have an interactive session till that. I'm sorry for this.
Dr. Piyusha, I have unmuted you temporarily. Can you please speak?
Now, can you just raise hand? How many people actually do craniospinal radiation? So 3 people have raised their hands. So how many people are doing in the conventional fractionations, in the conventional way of doing with the, or doing it with the helical based, like with tomotherapy or halcyon? Because the aspects are completely different, and we are going to talk about both the aspects and what is the concerns in both.
Sir, I'm still yet to get your presentation. I don't think you have mailed in the right ID. I have WhatsApped you my mail ID. Can you do it in that one, sir? Please check once.
Once. I'm sorry for the. But it has gone. DATT. Yeah, the medicine now. So what I can see that around 10 or 15 people do practice craniospinal radiation in this 41 people who are there. So, and how many are doing with linear based, and how many are doing it cobalt based in this group? Because there is a difference in the planning in that as well. Now, when you are doing with cobalt, you have to give it more margin because penumbra is more. So you have to spare a larger area of with the bones, frontal bone and the mastoid and the maxillary region. We have to spare it to see that there is no cold spot near the cubiform plate. Whereas when you're doing the 6 MV, we can actually have a lesser margin there. So how many are doing it cobalt still with craniospinal radiation? Today actually 2-3 things happened. Have you got it, Anupam?
Yes, I have got it, sir.
So can you just open the first one?
I'm sharing it. I'm opening the 2D part right first now. 1 second, sir. I'll just check. This is the.
Today what happened? We made the presentation and it got corrupt. So we had to just.
Yes, I could understand because you know I was finding it difficult to download it as well.
Yeah.
Just a second. So give me a few seconds. I'll just download it. 1 second, sir. So you can give a briefing of what you are going to go through.
Yeah. So now what we are going to talk.
It.
See what we are going to talk. Actually, I wanted to have it more interactive because we can always have a talk, but sometimes interactions are more important, especially in craniospinal radiations, because here it is actually the test. When I was in with Dr. Jalali, so it was a test of a radiation oncologist to have a proper craniospinal plan. If you are able to do craniospinal plan proper, you actually are now complete. You can do any radiation plan, which is now possible. So that gives an idea that what are the complexities there in doing a craniospinal plan. What we are going to talk is this conventional way of treating craniospinal is still relevant because many centers are still doing, most of the centers actually are doing that kind of planning, especially in prone position. And now few centers are started doing it helical. And when you're treating it helical, the junction concepts are less, but still there is a overlap region, and that need to be taken into account. We are going to talk about that as well. Now, you know, in this, we talk about this margins. We talk about putting the come to the first slide. Yeah. Because can you continue? Just next. Yeah. So craniospinal radiation, we need to treat the whole brain, the meninges, the spinal cord, down to the corda, and give a boost to the primary side. Now, many times there is a concern that whether you need to do a boost. There are studies to show that we have to give boost. If you don't give boost, then local failures are more. So boost is mandatory. But the challenge is, it is a very complex way of treating. Large area, it's an irregular shape. If you want to treat with a SSD, with the cervical region, lumbar region may not get that amount of dose. And if you treat in the lumbar region appropriately, cervical region can get a hotspot. So there are so much of complexities there because the curvature of the spine is not uniform. There is a curvature and there are two curves and which actually interferes. Next. So these are the structures. Next. We have to spend some time. So see the optimum way of covering the target, ensuring there is no hotspot in between, and ensuring there is no cold spot as well. So this is the optimum radiation therapy which is required, and to avoid the long-term morbidities, and also to ensure that adequate dose is delivered to the target area. Next. So these are the pre-op evaluations you need to do. A delayed post-op MRI scan need to be done for the spine, sometimes to see if there's any drop metastasis there or not, because that is going to change the diagnosis, the plan, the approach. Next. So we are treating in two phases. First phase is craniospinal, and second phase is boost. As we told that sometimes people think that we can go with the craniospinal only. Why you need to give a boost when a complete excision is done? There is study to show that no, the boost is required, and boost to the posterior fossa or boost to the tumor cavity, that we are going to talk a little later. Next. Now, this is how we treat Now we all treat him like that, right? In prone position, the two parallel opposite field for the brain and a posterior SSD field for the spine. And sometimes if it's a large spine or the adult patient, we have to do a second posterior SSD field for the lower or spinal lumbar spine. So there are junctions in the cervical region between the two lateral fields and the posterior field, and also one junction in the thoracic region or lower lumbar region, where there is a junction between the two posterior fields. So that is very interesting. Next. So what are the steps? You have to position the patient appropriately. Most of the time we treat in the prone position because it's easy to see. We can actually see which are the areas we are treating, but it is not comfortable for the patient. Many times we treat in the supine positions, especially when you're treating a CT-based planning. And that also has its own issues because we cannot see the posterior field which is going in. But it is comfortable for the patient. Patient need to treat for around 30 days. So supine position has its own value. Immobilization is important because we have to immobilize in the same position. In the prone position, immobilization has its own issues. And supine position, it is much easier, but we cannot see the field as we can see when we're in the posterior position. Simulation need to be done. We will talk about it. And the verifications that has to be done. And it is very important to have a proper verification. And treatment delivery is critical appropriately, and junction shift has to be done appropriately. Now, as I told, there are advantages of the prone and the positions. The prone is we can see the field, what is there. Disadvantage is there's uncomfort, and sometimes it is difficult to reproduce, and anesthesia is not possible. So kids are difficult to do a prone position. It has to be done in supine only. And supine has its own advantage that it is comfortable for the patient, but we cannot see the field size and all. In conventional, we usually do a prone position because we can see the field and mark it, and field matching and junctions and junction shifting, all this can be seen in that. Second, next. So I think everyone is use Csi board when they are doing in the supine position, but in prone position also can be done, and there is a different slots. Next. Yeah, these are the Csi boards, and we all have seen that. Next, there's the old slides. Yeah, so you need to put the position in the same, because see, there's very interesting thing is when you're doing a Csi, the cervical curvature, as much as we can compensate and make it straight, easier for the dose distribution to happen. So our positioning should be such that this cervical curvature is minimized as much as possible. So that is actually the intent of putting it in prone and putting the headrest. So it can be used as a reproducible device also, and putting the cervical spine in the same position as it is. Next. So now when we do the CT, you can see there are two lines, right? And there's a gap in between. And the blue line is for the brain, and the red line is for the spine. And there is a 5 millimeter gap in between. So there are a lot of debate whether we need to keep a gap or not, but in TMH we used to do that, and that we follow that principle. So most of the centers do keep a gap in between, and that has its own pluses and minuses as well when we are going to talk about it. Next. So first we do the spine field simulations first. Make it proper, see the spine, patient is in the straight position or back. That is very important because it's a large spine we have to treat. And if the patient is not in the straight position, then we cannot treat appropriately, and reproducibility is a big issue in that. And technically C1, C2 level, we have a junction most of the time, and that need to be straight, and that we need to put in proper place. And then the lateral fields we're going to put. Next. So sometimes we put in that if you go low, the shoulder can come in. If you go up, then the brainstem comes in. So the C1, C2 level or C2, C3 level is the area where the head field and the spine field junction should be there. and sometimes there's a narrow neck, sometimes the couch is rotated, and it becomes difficult. So C1, C2 level is a routine practice where we put the junctions. Next. So a lower border is actually the termination of the thecal sac, usually at S2 level, and that need to be covered. Now, the interesting thing is 85% of the patients do the thecal sac actually gets is terminated in S2 level, but there are 10 to 15% of the patients where at L5 level also they get terminated. So if you can put the lower border up, dose to the scrotum is less, and that has a huge impact in terms of sterility, in terms of sperm preservation and all. So if you are keeping the lower border high up, then the dose to the scrotum is much less, and that actually has a lot of impact. And that is why, and on the other hand, if you are missing that area, chance of recurrences are high. So you have to put a balance and try to save the scrotum with the dose as less as possible. At the same time, cover the area as much as appropriate as possible. So sometimes it is in S2, S3 level also. So you have to go down. So unless until you see where the thecal sac is ending, it is very difficult to put the lower border. That is where the MRI comes into the picture in craniospinal radiation. So most of the time you don't need to do an MRI. You have to see the MRI, which is the screening MRI done for the spine, to see that where the thecal sac is ending, and you need to put the lower border there. Next. So this is how the role of MRI, and you can actually see where the thecal sac is ending and put the lower border there. So it is mandatory to check the MRI film and before you put the lower border. Next. So SSD is a standard technique because it's easy to do, and you can put 80 or 100, whichever is the machine you have. And there is a no gap technique, which is a gap technique, and we are going to talk about it. So that is where the field matching comes into the picture. Next. So there are a lot of people, as we told, there are no gap argument, because there is a junction 50%. You know that what is the field size? Field light is 50% isodose line. So if it is matching, then that part is getting 100% isodose. But people say that actually the target is not in the skin; it is deep. And when it is deep, so there can be an overlap, and high dose can be there. So we need to calculate how much the gap need to be given in the skin to ensure that there is no gap in the target, which is 2 to 3 centimeter deep from the skin. So very interesting, and it actually has come from a proper mathematical model. And I couldn't put those slides, but very interesting that these are all has come from physics and mathematical model, that how much gap need to be done, and how much angle should be given, and how the junctions can be taken care. It was done almost 70-80 years back, but the principle which was followed that time, and the same principle is still followed when you're doing a conventional type of radiation in CSI. Next. So the gap calculation needs to be done. There are different ways of gap calculations, and this is a very complex way of gap calculation. Next. See, now you can see the gap. You see this, if this is the junction, it is the spinal cord, and the distance of the skin we can check. So we actually can see how much junction we need to keep. So these junctions are usually around 0.5 centimeter to 1 centimeter. If you consider the spine is around 2 centimeter deep from the skin, and usually it is kept like that. But interesting about the gap is every 7th fraction we are shifting the gap, right? We are doing a change in the field borders. As we are doing the change in the field borders, even if there is a little overlap, the feathering effect actually happens. And so the chance of having radiation myelitis is much less if you put a feathering effect. So many people argue that why you need to make it so complex when we are doing a feathering effect. So these are the components of doing with gap or without gap. But majority of the centers use a gap before they do the conventional type of radiation in craniospinal radiation. Next. So the moving type of need to be done, and we are going to talk. Next slides. See, there has to be a junction and feathering every 7 fractions or 5 fractions. We do a junctioning, and if you do that feathering effect, then the spinal cord never gets, even if there is a junction, never gets more than the tolerance of the spinal cord. So because we don't need to give more than 35 degrees. So that is why the radiation minorities will not happen. And many people argue that we don't need to give a margin in between, because we never cross the tolerance for the spinal cord, but that need to be done. Next. So the extended technique, because sometimes there's a adult patients, we don't need to have a junction in the spine, so we can do an extended technique, but then the calculations need to be done, output has to be measured, and most of the time we don't do that, and we prefer a junction, especially now as we are doing a CT-based planning in most of the time. So that extended SSG technique is practically not possible in most of the time, but when we are doing conventional, it is also feasibility, especially in the child, where we can cover the entire spine in one field. Next. So there are different ways of matching, and this is the most interesting part of craniospinal radiations. We can do a collimator or couch rotations. We can do a half beam block. We can use an asymmetric jaw. We can do penumbra generations, and then see how much it should be junctions, or how we can match the 2 beams. We can use wedge, and you can use tissue compensator to take care of the curvature of the spine. So these are different techniques to make the junctions less and make the dose homogeneous as much as possible. Next. So how to put the couch angle, as I told, there's a complex and interesting formula to set up how the couch angle and the collimator angle is put, and so that we can usually 6 degrees to 9 degrees the standard, and then we can compensate on the other side. That we usually used to do, but we have to see in the patient that how the match is done. Next. So now this is how we need to do. If you do a bilateral field, then there's a divergence which actually causes the junctions. And if you put a block, then we can make this divergence, omit the divergence, or we can collimate the beam and make both the spinal field and the cranial field match. And that is really interesting. Most of the time, we used to give 9-degree angle to the column, to the spine, to the cranial field, and 6-degree angle to the collimator angle to the couch angle 6 degree, so that we can match the beam, and that used to do. So that is what we used to do in many times, but that has to be individualized, and sometimes we need 7 or sometimes it's 9. That has to be individualized and checked in the simulation film, that how the match is happening. So this is the interesting aspect of doing craniospinal radiation. Next. So there can be shielding of the borders, and I'll talk next. Now this is very interesting thing. Now, one slide before, yeah, this is really interesting thing. Now when we do the shielding of the eye and the bones and the face region, so really interesting how much margin we should keep from the skull base. So that depends on the energy we are using. As we told, we are using cobalt, we have to give more margin. We are giving linear accelerators 6 MV, we have to give lesser margin, and to ensure that the dose fall off, which is there because of the MLCs, not affecting the causing any hot, cold spot into the cribriform plate region. So usually 1.5 to 2 centimeter margins are kept in cobalt to ensure that there is no hotspot. But when we are doing a planning system, we always see that the cribriform plate is always covered with the dose we are prescribing. Now, interesting thing is, medulloblastoma or craniospinal radiation is one of the very few areas where the quality of radiation actually has affected the outcome. Now, there are two studies with small cohort of studies, but it has shown that if we have deviations from the plan, both in terms of covering the cribriform plate and covering the posterior fossa properly, giving the boost and giving the margins to the boost, there is a failure in either in the cribriform plate region or in the posterior fossa region. And that has affected the outcome and the survival. So really interesting that quality of radiation this is one of the first area where the quality of radiation actually is an important factor for predicting the outcome. And that is where high volume centers do have a better outcome in medulloblastomas because the quality of radiations are maintained and the quality assurance is done for planning as well, not for the machines only. Next. So this is what is done. Next. Now this is what the MLCs are put. We have to see the frontal bone, frontal sinus, half is covered, maxillary sinus half is covered, and we see that there's a margin given to that. I think here the coverage is a little more. Next. So when we do the treatment verification, it has in the prone position, it is easy to do. We can actually check the field borders. We can see that it is covered. We see the matching is done or not. Usually red and blue markings are there for the red for the spine and blue for the brain, what we used to do, and see that it is matched or not. And then we should do either portal imaging or some kind of verification methods to be done to see that matching is done or not. If the patient is not in appropriate position, we can miss the spinal cord, and that is why you can match the brain, but the patient is not in the straight position, so you can miss that as well. So it has to be, so positioning has to be and verification has to be done not only for the brain, for the spine as well, upper spine and lower spine both. And that same problem, same matching system is there for helical treatment as well, and that we are going to talk. Next. So next. These are old slides. Next. So junction shift. We need to do junction shift every 5 to 6, 7 fractions as we do in one directions. Next slide. In one directions, it was the animation was there. I'm sorry, it didn't work out because it got deleted. So we have to move in one directions. Usually 1 centimeter movement is done 3 times and every 7th fraction. And if you do that, then the chance of it is a feathering effect, and the chance of hotspot or radiation induced nerve damage is much less. Next. So about the posterior fossa boost, and there is a margins to that and need to be done. And where we need to give the posterior fossa boost, where we need to give the tumor bed boost. That is very interesting thing. Now, when you're doing the posterior fossa boost, we are treating the entire posterior fossa, mostly in high risk medulloblastomas are there or high risk patients are done. When there's average risk, we can give give only into the tumor bed with the margin. Usually 10 to 15% of the cerebellum is spared if we do only the tumor bed with a margin boost, 1.5 centimeter margin boost. And there is something called comparator of servo mechanism. Now it has been shown that in average risk patient, if you give only tumor bed boost with a margin of 1.5 centimeter, we can spare some cognitive function effect, because comparator of servo mechanism where the cerebellum is involved, it actually helps in preserving the cognitive function. Next, there are some, we know that Halperin's triangle. So next. So these are the dose prescriptions. I don't need to talk about it. Next. So beam energy usually 4 to 6, as in gives a homogeneous dose distributions are required. And electron many times we don't use, but there's options. Next. So CT simulation, now when you do a CT simulation based, it actually has its own advantage. So we can see the thicker sac, we can see the cribriform plate, we can see how much is covered in the skull base region, and that actually helps in seeing the dose delivery also, and see how much the dose distribution are there any cold spot or hot spot is there in different area or not. Next. So advantage is it can see, we can contour the organs and see what is the way as getting dose, and we can see the dose distribution parameters, which is not possible in conventional treatment schedules. Next. So there are different steps. I don't need to talk about it. We can put the position and plan it and do the scan. Usually do a thin slice CT scans for that. Next. So this is the CT simulations. What we can do, we actually can do the cranial field, the spinal field, match the fields, and give the angles, the couch angle and the collimator angle as it is required, and individualize as per patients. See the dose distribution parameters and see that how much hot spot and the cold spot is there. We can actually plan the junction shift as well in one go and have a fused plan to see how much dose after the junction shift is happening and these areas are getting. So we can have a composite plan of all the junction shifts plans and get a combined plan and see how much dose different area is getting. That actually helps to see any hotspot or cold spot region in different area. And I think most of the people are now using the CT-based planning as only. Next. So this is how we have to contour the eye, contour the optic chiasm. Now, one very interesting thing is, most of the time I have seen that people try to spare the lens. Now the lens max dose is 6 gray, which is very difficult to achieve. And if there's a cataract, which can happen if radiation is going to the lens, we can do a cataract extraction and replace it with the lens. So that is not. But if you underdose the cribriform plate, we can have recurrence, and that has huge implications in terms of survival outcome. So most of the time, we don't need to think about the lens dose, but we need to think about the cribriform plate coverage. Next. So you have to check it, match it, and see how all the things are, but how the matching is done, and then treat and do the treatment delivery. And with the CT-based planning, it is possible. And now most of the centers and throughout the world actually now started doing the CT-based planning for craniospinal radiations. Next. So positioning is supine, position need to be done for CT-based planning. And we have to check the alignment. See, neck has to be neutral position as we discussed, and then plan it next. Next plan it, and we have to as standard we have to block the eyes, oral cavity, the salivary gland if it is possible. But as I told, we don't need to bother too much about the lens. We should check the lens dose. And if possible, we should try to spare it as much as possible, but not at the cost of the cribriform plate. Next. So this is the position and to be treated accordingly. Next. We can actually have discussions how. So this is how we have to the block area need to be done, and the brain field we need to do, and spine field we need to do, and you see how we need. But in supine position planning, the problem is we cannot see the field lights. So as we cannot see field lights, if the patient is not in aligned properly, we can miss a part of spine, especially the lumbar spine. We can miss it. So that we have seen always that it is not in the center position, and so it has its own impact. So that has to be very accurate, and through the laser lines and putting the patient and checking before we treat that the patient is aligned properly. Next. Yeah, this is what we see when we deliver deliver in the CT-based planning. Next. So there has to be a QA planning. There has to be evaluations for how we are treating. Next. So this is next. This is how the collimator angle is done. This is the MLCs, how they are put in MLCs. And this is how the conventional type of radiation is done. Now, if anyone have any question, we can raise we can talk, and we can go to the.
Sir, I think Dr. Abhay has a question. In feathering technique, how should we shift the gap? It means he wants to ask by how many vertebral levels should we shift the gap in one fraction. I think, sir, you have answered it in one of your slides. If you can elaborate it
So
again.
usually we plan upfront only that how much we will shift. We shift in the same direction 1 centimeter. So 3 times 3 centimeter before, because there are tattooing. I have not shown those pictures. There are tattooing have to be done when we used to do the tattooing for the spine. So the lower border is fixed. The upper border of the lower cervical field actually goes up 1 centimeter each, and the lower border of the upper cervical upper vertebral field goes up 1 centimeter each, and as also happens in the lower border of the cranial field as well. So usually 1 centimeter shift, three shifts used to be done. So 3 centimeter gap used to be. Now, unfortunately, or fortunately, we are treating mostly with helical therapy treatment, where these junctions are not there, and we can treat entire region in one go. Can we start the next? Next.
Yes, sir. We can start the next one.
Yeah. So now, what we had to talk is for the old type of radiations. Though we call it old, but still maybe 70–80% of the centers are doing that only, and treating with a conventional type of radiation for the craniospinal radiation. But now the contouring has come in. So as we are doing more of a helical type or arc type of treatment, so the contouring is now critical. So there are contouring guidelines, but they are very simple guidelines. Now, thing is that what is our target? Our target is the entire leptomeninges, brain and the spine. So that need to be covered. So wherever there is an area where the leptomeninges can go in, like all the foramens, the nerve roots, that need to be covered. Cribriform plate, where the leptomeninges is protruded, that need to be covered. So basically, we need to cover the leptomeninges. So that is the guideline. Next. So see, this is the same what you spoke. So it is a complex way, but putting the same thing to cover the leptomeninges. Next. So these are the different foramens that need to be taken into account. And as sometimes the leptomeninges can go along with the nerve to some extent, we need to see whether it is going down or not and cover that so that recurrences does not happen. So when you're doing the contouring in the skull base region, we need to be very careful to see that all the foramens are covered, and all the foramens are covered with some margin that need to be done. Next. So the inner tibia of the skull is outlined and using the bony window and contoured as a CTV brain. And then we ensure that cribriform plate and all the fossas are covered. And then we see that dura of and the spinal, that extensions from all the nerve roots from the spine is covered. Next. So these are the areas we ensure that it need to be covered when you are treating, because see, you can see that here there's leptomeninges is going, there's protruding. So ensuring that need to be covered. Next. There's one more slide. See all the foramens, you ensure the foramens are covered. So these are basics that we need to cover all the foramens from where the leptomeninges are going in. Next slides. So see, we have to, usually we should contour all the structures, ensure that they are covered in our CTV, and a margin is given to that. Next. So this is how we see when we are seeing the plan. Next. Go. So you see that the cribriform is always covered. So that need to be covered appropriately. Next. From one of our patients, we have Next, see, this is the isodose. You can see the 35 gray, 30 gray, how it is. Now, what actually happens that with this kind of helical kind of treatment, what we are doing in this case with tomotherapy, see that it is very confined. High dose is very confined. But you come next. But see, low dose pill is there. When you're doing when only the posterior field, there'll be a high dose region which is going in and covering the spine and adjacent area. But low dose pill is much less. But here, the low dose pill is also there when you are treating with a helical kind of therapy, but at the cost of homogeneity. So you get the homogeneity, no hotspot region, but low dose pill is there. So there has to be a balance between how much low dose we'll accept and what kind of homogeneity we require. Do we need to have a full homogeneity, or we can compromise on the homogeneity and ensure that a low dose pill is less. So that is some techniques need to be followed, and usually we try to confine as much low dose as possible. Next. This is the posterior fossa. I couldn't see the MRI. Yeah. So this is the posterior fossa that need to be contoured in the pre-op scan. Fuse it with the MRI and pre-op MRI is fused with the CT scan. Also the post-op. See what is the cavity and taking into account what was the pre-op volume was there. Always have to fuse or try to fuse the pre-op MRI of the brain, fuse it, see, contour the structure as GTB, which was there, and then contour the cavity and give a 1.1 to 1.5 centimeter margin to see the CTB for the cavity, and need to given a boost to that. And boost is mandatory, and because if we have seen that if we are not giving boost or compromising on the target of the boost, there is a chance of failure is high. So that is where the high precision. Now, when you're doing the helical type of treatment, sometimes we can incorporate the boost also along with as a SIB kind. We can do that, but most of the time we don't do it in terms of making it more complex. So we finish the CSI part and then followed by the boost. But there is always a possibility of including it as SIB boost in the posterior spine. Now, what I have not included, right, I couldn't get the photographs, is that how to match it. And just kind of put it, we can talk about it. Just last slides, yeah. So now, if you see how we match when you're doing a helical treatment for this, we match the brain, then you go down and match the upper spine, and then match the lower spine. Now, if you match the brain and then match the craniocaudal part, and then go to the upper spine, and then match the craniocaudal and correct it again, then the brain matching is gone. Then we cannot take it into account. And then when you come for the cervical or lumbar region and match it, then the cervical region matching is offset. So it is very complex that though we talk, there is no junction when you're doing a helical kind of treatment, but it is not completely true, because when you're treating the brain and then coming down to the spine, patient can move in between and there can be a junction. So it is not that there cannot be any junction. And when you're matching the brain and treating the spine, then, and without matching the spine, you can miss because you have not matched the spine. Now, if you match the spine and treat without matching, and before you match the brain, then there can be a junction in between because it is a helical treatment. You understand that there can be a junction in between also. So it is a very complex, and Dr. Tejpal actually has given a nice formula that how to work on it and how to see that it was done long back, 2010, this paper has come, Jubin and Dr. Tejpal has done this very interesting exercise to see how we can actually correct the lateral movement, pitch yaw, but not the craniocaudal movement when you're doing this, matching the spine, or cervical, of matching the brain. And when you're coming to the spine, that time also we are not compromising or not not changing the craniocaudal or caudal matching what is done in the brain part. So then the chance of having junctions is much less. So it is very interesting thing that even in helical, there can be a junction, and that need to be taken into account. I hope it was useful. It was made in a hurry, but yeah. See, we actually do that. We match the simulated cranial field first and then the spine field. It is done always in that order only. And when you are doing the treatment delivery, that time also same thing is done. We first match the spine, we match the brain, match it. We don't move the above the craniocaudal, then miss the upper spine, then miss the lower spine. Lateral movements, pitch, roll, yaw is corrected, and then we go back again and treat from the cranial part. So that is how the treatment is done for the craniospinal with a helical form of treatment. I hope you understood, because it is a very complex thing and the slides were missed in between. But I think it was. I think anyone has anything to ask, we can have a discussion.
Thank you, sir, for such a lucid presentation on such a difficult topic. Residents in the audience and anyone else, if there are any questions you may have to ask, sir, please go ahead.
Yeah, can you ask the question, please?
Sir, as I see, there are no further questions as of now.
Fine.
I have two questions actually.
Please go ahead, Kanu sir. Please go ahead.
Yeah.
So when you are planning with 3D, how much underdose you accept in the junction?
Yes, that is very nice question. See, usually we don't accept underdose in the junctions. 80%, 85% isodose line has to cover in the both, because you know that there is every 7th fraction there is a shift. So that part is anyway going to get the full dose. So if we 80-85% of the these there at any point, we accept it. We don't want 210, 115%. We don't want there.
So actually, if you give 5 mm, definitely there will be only below 60%.
Yeah.
But if you do 3D planning, if you do in the you need the CT planning with 3D planning, if you do, it is usually comes 3 mm.
Yes.
If you go for 5 mm, it is definitely below 60.
Yes, I agree completely.
Okay. So what is the lowest junction level you see take a craniospinal?
Craniospinal. See, many times if it is too close, when we're doing a CT based planning, we don't need to calculate on our own. The system is going to calculate, right? So we actually give a junction of maybe 3 millimeter.
No, I'm not. I'm asking what is the lowest C5 or C4?
It is usually C4, and because you know why? What happens? If you give C5 and then 3 centimeter up, you do. Sometimes it is some issue. So C4 or C5 upper border is okay.
So if you open field matching and versus half beam block, but if suppose you take brain half beam block and spine half beam block and give another field in the lumbosacral area. Yes. So what is your opinion?
See, half beam block is good. The problem I'm telling you, half beam block is na. So then your machine has to have a 40-40 field.
No, if I'm pediatric age group, I'm telling.
Yeah, in pediatric age group also, usually it has to be 30 field, right? 30 fields. Many centers will not have field of 30 or 40. They have 20 maximum field size. So then half beam block is not going to work there. No?
Okay, if it is a small kid.
If it is possible, I always prefer half beam block because it is easy to put. Complexes are much less with that.
You prefer Delhi
in Amrita Institute, we do half beam block. And you know, in TMH, we never used to do half beam block. We used to do.
Yeah.
only.
So what is your daily feathering or weekly feathering? Where do you better?
We are doing a weekly feathering because it is easy to do.
Okay. What is your extended SSD? If you plan how much extended SSD?
We don't do it. We don't do it here because sometimes machine don't see. Now we actually can match it daily, because we are doing imaging daily for treatments, and so we are not too much bothered about the junctions in the spine. So it makes a lot of sense to do a standard SSD only, because the calculations, and again you understand the complexities of doing extended field is we have to do a recalculations for everything, because machine is calibrated with the same SSD what we are treating.
You think that 105 or 1010 is okay for extended SSD?
1010 is okay. In TMH, you know that we used to many times used to treat with 110 or 105. We used to treat to cover especially in a pediatric age group, so that there should not be any junction. But on many practices, we don't do it outside TMH because of little other complexities, and we can match it with this imaging daily before treatment.
So flexion extension, if you putting in the patient
neutral position.
Always neutral.
Always neutral. I prefer neutral position.
Okay. Do you include sacral canals?
Sacral canals, we.
But that European Csi guideline told no need.
No, see, problem I'm telling you, if you try to put a sacral canal full, then lower part with the area is much bigger. Now you understand. So
now spared field, people are now. But if there is if Csi guideline tells that don't include the sacral canal, so we cannot we can spare the spared field. We will just
absolutely.
Okay. So still boost, which is more safe, boost or posterior fossa boost or CTV boost?
See, for average risk, you can do a CTV boost, but for high risk, posterior fossa is much maybe more. There's no, we cannot say which one is better than other, but the chance of recurrence is little on the high side. So, and more aggressive disease, prognosis is not good. So for high risk, we always prefer the posterior fossa boost.
Okay, thank you very much.
Sir, this is Anupam here.
Yeah.
Sir, the slides of hippocampus pairing RT that you have sent me, there happens to be some issue with that. They are not downloading. So what I will do is I'll share the screen of the Chrome in which I have opened the slide. Okay. So it will not be entirely in PowerPoint format. It will be like a PDF rolling up and down.
What I'll do now? See, I have not put too many slides. We can have a discussion.
There are 11 slides. Yes.
11
slides.
That is yeah.
Just see if you can see the this thing, sir. Just check.
Sometimes though high techs are good, but high tech has its own issue as well, right?
Right, sir. I'm struggling with that part only. So I'll just.
I'm not able to open. I don't know. I'm not able to open.
I think you have not given your Mac the access to open in a Zoom meeting, because Mac shares the privacy settings of sharing your data in Zoom.
In the Mac, if you want to present the presentations through Mac Apple setup, it will not allow.
Yeah, I'm doing it through Mac only. I'm not having any problem, but you need to give a prior
information, security information.
Yes.
This is complex.
So I'm doing it, sir.
Yeah, please.
So just give me a couple of seconds.
I hope it was useful, right? It was little complex.
It was useful, sir. Absolutely. So I guess you can see the screen now.
Yeah, I can see the screen. Can you just specify? Now, see, we are now. See, you people also can join. Now we have in Amrita Institute, we have form a consort for meta-analysis and mostly meta-analysis, and we have done a group which we had the statisticians are there, and we are working on that. So we have published a paper on meta-analysis on the memantine in brain. Now we are working on it on the hippocampus pairing. It is really interesting that though we always talk about that hippocampus pairing is the thing and should be done. Now when we've gone through, there are these are the actually articles which are relevant. Let's just keep it there. So articles. Now, actually, there is only one article which more than 8 weeks follow-up is there. So if you want to see the hippocampus pairing effect of radiations and what is the impact on the cognitive function, we need to have a long-term follow-up, at least 1 year follow-up, because then the re-radiation, the impact of re-radiation is going to come into the picture, right? So there is not much data available. So though we are talking about hippocampus pairing, but there are a lot of work need to be done before we make it a standard of care now. Because so much of hype is there. There is data, and we also do more than 4 lesions in brain. We treat with hippocampus pairing only if the performance status is good. But at the same time, we know that these patients which are having more than 4 lesions are not going to live more than 6 months. So do it hippocampus pairing, do whole brain RT, not much impact on terms of cognitive function will happen. Unless until 30-40% of the patients are alive at 1 year, where we can see the impact of cognitive function sparing, the doing hippocampus pairing has not much value in clinical practice. So that is what I wanted to share this table, and you can get all the literatures and see very interesting observations, and we are putting it in our meta-analysis, this one only. So this is the fact, and then come to the presentations, right? So hippocampal sparing, if you want to do, always need to do an MRI. Without a proper MRI, T1 contrast, FAT-SAT, 3D FSPGA sequence, you will not able to do, because you cannot see the hippocampus proper. What are the borders are there? You have to see the putamen, you have to see the thalamic nucleus. You cannot see it. So in CT scan, you cannot do it, period. In a CT scan, MRI which is not a 3D FSPGA, means zero gap is not there. Proper contrast is not given. You cannot see it. So if you want to see it, you have to do a proper MRI. Next, go ahead. Now, another thing is, when this is a patient with 5 or 6 lesions in the brain, so we did a hippocampus pairing radiation, but performance status was good, and patient was a teacher. So our cognitive function preserving was important in this patient. Now can you go down? Now, there is very interesting thing. When you are doing hippocampus pairing, you need to contour the hippocampus as per the guideline, and we will one day talk on the guidelines proper, because it will take another 1 hour to do it. And it is very interesting to see that what is the guideline and how much deviations we can do from the guideline when we are contouring it. So that is one. We have to give a PRV. If you don't give PRV, then you will never achieve the constraints which Benagondi has given. So you have to give a 2 mm, 3 mm PRV, and then subtract from the whole brain that both hippocampus joining together. Then that will be the brain, the PTV minus hippocampus, and you need to consider that as a target and do the planning accordingly. So the concept is, we have to max dose is 15, no 14.5, 15, and minimum dose is 9 for the hippocampus. That is accepted, and 95% of the brain is not getting less than 28 gray. That is the criteria for covering. So when you're doing that, just go down. So when you're going to do that and approve the plan, we need to see that these constraints are covered or not. Okay, and the max 32 is the max dose for the C. Whenever trying to cover or spare the hippocampus, there are some hotspot come here and there. I think those people have done, we will see. So that also is a real concern, and that need to be taken into account. So when you are contouring the hippocampus, 2-3 things. One thing is, patient has to be performance status 1 or 0. Patient has to be more than 3 or 4 lesions. Patient need to expect survival more than 6 months at least for doing a hippocampus pairing, and need to contour the hippocampus, give a PRV margin to that. And that the whole brain minus PRV will be your target volume for the faces to contour. So if you don't do that, you never get achieve the acid, because we have seen sometimes put the hippocampus and minus the EA, then you'll never get the, because 9 gray max dose, 9 minimum dose, or 15 gray max dose will never happen. And we want to give 29 gray to the brain. It is difficult to achieve. And so that PRV margin is required. So that is the crux of the thing. And always see the cochlear dose, because we are doing high precision radiation. So you want to spare the lens, the optic nerve, and we want to give less dose to that. So as we are, so cochlea and lens dose are important when you're doing a hippocampus pairing, because you are expecting this patient to live long and live more than 6 months. So you don't want a cataract to happen in these patients. So these are the small things for hippocampus, and we sometimes may, if Anupam wants, we can have a long discussion on hippocampus someday. Anupam, it's okay?
Yes, sir. It's perfectly fine. So just I had one query. Now you have said that patients whom we expect to live more than 6 months, and we usually do it by the DS-GPS scoring.
Yes, absolutely.
So in such cases, should we go ahead with the hippocampus pairing whole brain RT, or should we go ahead with the stereotaxy?
No, fine, stereotaxy. Now that is a big thing. Now see, usually what happens that when you are doing a stereotaxy for a brain metastasis, criteria is very clear. When the patient have a recurrence, we are in a position to retreat again. Now, if someone is having 4 lesions in the brain or 5 lesions in the brain, and you are treating with stereotaxy in that, probability that a new lesion coming is really high in 3 months' time. That time, you may not be in a position to retreat it again. Okay. So if the first time you're treating with radiosurgery, and when it comes back in 2 months' time, 3 months' time, you are not able to treat it again, your first SRS is failure. So that then it makes sense to treat with whole brain RT. Now, the difference between the whole brain RT and SRS and the local failure rate is 14%. Okay, so if you are not giving the whole brain RT and doing this SRS, you are actually accepting 14% higher risk of recurrence, and you are accepting that you are going to treat that with radiosurgery when it comes back in those 14% patients. But 70-80% of the patient will have a cognitive function sparing if you do a radiosurgery, stereotaxy.
Right.
So in someone is having more than 4 lesions, the chance of recurrence is more than 50-60%. So if you're doing a stereotaxy, you are accepting the chance of recurrence 50-60%. Do you want to do that? No. You don't want to treat a patient where the chance of recurrence is so high. So that is the reason why we don't treat. It is not that you cannot treat, but then you in the follow-up setting, you may land up in trouble. And if you follow those patients, you may see that these patients are not doing well in the long run. So it doesn't make it is not about stereotaxy alone. Amount of effort you put in the patient, not doing the stereotaxy. So it is not about the money alone for the patient, which is our effort as well, right? So why we need to put effort so much when we know the chance of recurrence is 50-60% in this group of patients?
Yes, absolutely. Very well spoken. So just to everyone who's present over here, do you have any questions for Dr. Devnarayan or for Dr. Kanucharan Patro? Because these two people, they are probably the present pioneers of CNS malignancy treatment here in India, and you might not get another chance to clear up your basics. So please do not feel intimidated by them. They are extremely, extremely humble people. They without any judgment, they will always be there at your, this thing for any form of clearance of your doubts. So anybody, if
I have some questions actually.
Yes, sir. Yes, sir. Please.
So if you go to the RTOG trial, Binagondis article, you see they are given 30 grain 10 sections with a
Hello. Yeah. Kanu, what happened to you?
Kanu, sir, you are not audible.
Okay, not audible.
Now you are audible, sir. Please go ahead.
So if you go to the Binagondis article and RTOG study, if you go to the study protocol, so if you see the whole brain hotspot is around 37 gray. So how is it acceptable to you when you are planning for the 37 gray is a hotspot inside the brain. You are giving the 30 gray in 10 fraction and going the constraints.
Now it depends on what kind of machine you are using. If you're using a helical treatment, like what we do, we never get 37 gray max dose. You know that max dose is 101, 102% in a helical treatment. That is the beauty of doing the helical treatment.
No,
right?
even in a helical treatment,
we don't accept. So see, as per the Gondi's criteria, 32 gray is actually the max dose we accept.
No, 37 they have given.
37, but we don't accept it. We accept 32 gray.
32 gray. So if you go to the RTG protocol study,
The problem I'm telling you, problem is if you do 37, the probability of radiation necrosis is high, and you do such a high-end treatment. Why we want that to happen?
Yeah. So as you told, you give the hippocampus to the PRV around 5. That is called the hippocampal avoidance zone. So when you are seeing the criteria for the mean 9 gray to the hippocampus or hippocampus avoidance zone.
No, but the catch is when you are doing the planning, we are doing the PRV. But when you're seeing the volume or the dose constraint, we are seeing for the hippocampus, not the PRV.
Yeah. So not the PRV.
Not the PRV. Then you will never achieve it.
So how, suppose one patient lesion is in the thalamus. So how much distance from the hippocampal evidence you don't treat with hippocampal evidence?
See, if it is within the reach of hippocampus, because see, if you want to treat that thalamus and spare the hippocampus, it is not going to work out. So usually if a ipsilateral hippocampus region is involved, we don't do that hippocampus pairing, opposite contralateral hippocampus. Now there are enough data to show that contralateral hippocampus, single hippocampus pairing also is useful.
So
there are some data on that.
Thank you, sir. That was also quite a lucid and animated discussion, I would rather say. So thank you, Devnarayan sir, and thank you, Kanu sir, for making yourselves available for us. I got a lot to understand and lot to know and lot to fine tune my skills. And I guess with me, the other people attendees will also might have got an equally enriching idea about today's session. With this, maybe I would request Debanjan to close the show, and it's a good night from all of us. Thank you. Excellent and festive greetings to all of you. Thank you so very much.
Thank you, Anupam, and thank you all for this invite.
Thank you. Thank you.
Thank you, sir.
Yes, we are calling it a day. Good night and enjoy the puja, everyone.
Thank you. Thank you.